All right, so I wanted to go quickly through some potential prospects for the next several months. So Shelley had asked me to maybe put my Karnak the Magnificent hat on and think about where things might go over the next several months with COVID and flu and RSV all seeming to be on the verge of kicking up. So I did my best swag to kind of project out over the next couple of months and what the winter is going to look like. And we'll talk about that now. So the first thing is just highlighting the complexity of what's happening with COVID here over the last several months. These graphs represent different variant prevalence across multiple countries, and you can see the US is in the bottom right. Across all of these countries, previously variant waves had been dominated mostly by one or two variants. And so predicting behavior was a little bit easier. And now, as you can see on the far right of all of those over the past 6 months, we've had the rise of multiple different variants that are co-circulating, and projections indicate that that trend is going to continue, which makes predictions about the behavior of the virus, I think, a lot more difficult. So with that context, we'll talk about what we can potentially expect with COVID going forward. So this is a representation of current variant prevalence across the US. Data are complete or mostly complete through October 15th, and then the CDC Forecasting Center provides nowcasts of estimating what current prevalence is. And you can see that BA5, which had been the predominant variant, has been dropping off considerably, and it's being replaced by multiple different variants. But the ones that are growing the most rapidly are BQ1 and BQ11. And if you look at prevalence of those two variants over the last couple of weeks, it looks like we have a doubling time for BQ1 of about 12 to 13 days, and for BQ11 about 9 days. So overall, for both of the BQ varieties, we're looking at maybe 10 or 11 days in terms of doubling time nationwide. Now, this is data from Region 2, New York and New Jersey, and you can see that exponential rise in BQ1 and BQ11 that's been occurring over the last month, and that I think is projected to continue. So it looks as if those two variants might become the predominant variants, at least in the first part of the winter. That's obviously not consistent across much of the country. Region 2 in New York and New Jersey are ahead of the game in terms of prevalence of BQ variety variants compared to the rest of the country. So if you look at that doubling time of 10 or 11 days and where they are now, we can estimate that BQ1 and BQ11 will combine to become the predominant strain of SARS-CoV-2 present in Region 2 probably within the next week. And so they'll cross that 50% threshold, where the combination of those two represents more than 50%. I think it'll be late November before places like our region, Region 7, and some other regions like 6 and maybe even 5 before they cross the 50% threshold. Now, that 50% threshold is important, I think, because we've seen in the past, that's when you start to see the inflection point of epidemic waves for variants causing a new significant wave. It's when those variants become the predominant majority of sequences of isolates that you see that epidemic wave kick off. So I would predict that when we hit that inflection point of 50%, that's when we're going to start seeing rapid growth of cases exponentially in those places. And so again, for the East Coast and kind of middle Atlantic northern part of the country, that may happen as soon as within the next week. And then for our region, that'll be the end of the month. Now, obviously, it takes usually 3 to 4 weeks for those epidemic waves to build up to a peak. And so we're looking at peaks in mid to late November based on those projections for COVID. Now, what is the magnitude of that peak going to be? I think it's hard to tell for sure, but if you look at what's happened just recently in Europe, comparing kind of BA5 progeny variants mostly in those epidemic waves that peaked recently in Germany, France, and Italy, you can see that in places like Germany, they approached or surpassed, actually, in Germany's case, the peak of hospitalizations that they saw during Omicron or BA1. France and Italy were somewhat less. And so maybe you can at least expect hospitalizations of the magnitude of what we're seeing in BA1 or Omicron in January of 2022 from those European countries. Now, important to note that vaccination status between European countries and the US are quite different. So we're a little bit closer in terms of the number of people who've completed a primary course. You can see that we're about 68%, where these other countries are in the high 70s or low 80s. But the real difference occurs in boosting, as we've talked about before. And this means that we have many fewer people who have recent doses of vaccine and who've received more than the baseline 2 doses. You can see the US, we're still at a pathetic just over 40 boosters administered for 100 people. And some of those are people who've received multiple boosters. So total population who's received a booster in the US is under 40%, as you can compare that to these European countries, which is much higher. And so that means I think they are much less vulnerable to hospitalizations per case count compared to us. And so I think we can expect something much more similar to what we experienced in January of 2022. So nationwide, that shows you the peak that we saw in January of 2022 in terms of hospitalizations, actually the highest peak that we experienced in the pandemic. And I think, unfortunately, our hospitalization peak is going to be similar. And again, will vary across regions. I think regions with higher vaccination and boosting rates, like the East Coast, will actually do somewhat better. Regions like ours, which have lower boosting rates overall, will probably do worse. So if we're looking at expectations for Region 7, our peak in January of 2022 was between 6,000 and 7,000 hospitalized cases per 100,000 per day. Now, that's not admissions, that's hospitalizations. If you think about the average hospitalizations, around 5.5 days for COVID, and Region 7 population's about 11 million. That means it's about 11 new hospital admissions per 100,000 per day was where we were at our peak. And that's probably what we're going to approach, I'm guessing, by December, January of this coming winter. So again, we're going to initiate this new surge in mid to late November across the country. We'll be a bit later than that. The peak will probably occur in late December. It may push back into early January. We'll probably be in the later part of the US overall peak. The magnitude will be similar to January of 2022 or Omicron BA1. And there's lots of wild cards that we need to think about in terms of Halloween effect, Thanksgiving effect, Christmas and New Year's holidays effect, and then any other variants that may pop up in the interim. 2 months is a lifetime in the world of COVID these days. And so new things may appear. Now, if we look at what's happening with flu, I think that's the kind of the second part of this triple-demic that we're staring at. And what we're seeing with flu, unfortunately, is much earlier activity and much higher rates of influenza-like illness than we've seen certainly in the past couple of flu seasons, where we've essentially had almost no real seasonal influenza. The trends so far, what we're seeing now, as you can see, already above the epidemic threshold and quite a bit earlier, about 4 to 6 weeks early, even close to 8 weeks early compared to what we normally see in seasonal influenza. So it indicates that we're probably going to see an influenza season that peaks earlier, but probably is of similar magnitude, at least based on the current trajectory of prior seasonal flu epidemics like 2017-18, 2018-19. And so looking at kind of a typical flu season so far is where the trends go. Now, in a typical flu season, it takes about 8 weeks to get to the peak after you cross the epidemic threshold. So that means we're probably looking at, again, early December, early to mid-December before we hit a peak nationwide. It's also true that the high points of the peak last about a month to 6 weeks over the course of the entire, or over the geography of the entire country. It's a bit shorter when you look at specific localities. And so influenza peaks in a community may last only a couple of weeks, but over the entire country, that spreads out to about 4 to 6 weeks. And so we're looking at, again, kind of the months of December and January as being a very high influenza incidence over the entire country. Now, what we see with hospitalizations is flu tends to correlate with the predominant virus that's present at the time. So in H3 dominant years, we tend to see higher rates of hospitalization and death because that primarily hits older people harder. And so you can see that we have different rates of hospitalizations across multiple influenza seasons, 2017, 2018 being an especially bad year, 2019 and 2018-19 were kind of average. Now, if you look at the overall pneumonia influenza mortality curve, you can see that these H3 dominant years, so 2014-15, 2016-17, especially 2017-18, those tend to be the worst years in terms of hospitalization and deaths. H1 dominant years, less so, as you can see there. What we're seeing so far this year is it looks like an H3 dominant year. Most of the isolates that are being detected now are H3N2. And so we expect, in terms of hospitalization and mortality, a slightly worse than average year for seasonal influenza, again, if trends continue the way they are. So what we expect in kind of the peak weeks of influenza demand, we see roughly about 5 influenza admissions per 100,000 per week overall. And again, that's in a more severe H3 dominated year. And you can see that's still less than half of what we see at COVID peaks previously, but shows you that if we see kind of a similar COVID wave to last year and what we expect, or what I expect at least to happen in December and January, and we have a relatively normal flu season, that's an additional 50% in terms of hospital burden on top of the COVID burden. And that's something we haven't experienced in the previous epidemic waves of COVID. The last thing to talk about is RSV. And RSV has, as everyone knows, been especially bad already this year. RSV tends to have long seasons of activity during the winter and cold months, and generally peaks around December, January. In most places, you can see here that we've already started a pretty rapid rise in RSV detection across the country. That's also true in our region. And peak activity you can expect between mid-November and early January. So peak activity, again, generally spans a couple of months. If you look at previous years of RSV, the entire season, again, lasts most of the late fall and winter into the early spring. And again, as I said, tends to peak in December or January. Also important to note that the burden from RSV is a lot more significant than I think most people recognize. We think about it mostly in kids, and it's true that there's a tremendous number of hospitalizations in children under the age of 5. And proportionally, that's much more significant because we generally don't see kids of that age hospitalized. But it's also important to remember that 60 to 120,000 hospitalizations per year are thought to be due to RSV in adults 65 and older, and up to 10,000 deaths per year in adults 65 and over. So again, that's almost a third of the influenza burden that we typically see in a normal year for adults over the age of 65. So combining all 3 of those potential epidemic waves together, all of which seem to be peaking in the US around mid-December to mid-January, is not necessarily a heartwarming prospect for what we can expect here over the next couple of months. Now, again, previously when we've seen large COVID waves, that's tended to kind of essentially push out and inhibit activity in communities of these other respiratory viruses. But that doesn't necessarily mean that that's the same thing that's going to happen this year. It's also true that in previous years, we were using a lot more non-pharmaceutical interventions, and we are not doing so now. And so I think it's certainly possible that we're going to see all 3 of these epidemic waves coinciding, and our hospitals and healthcare systems need to be prepared for that. That's all I got. Thanks, Shelley.